Good morning. I'm Angie Riccono filling in for Dr. Stites. This is Open Mics with Dr. Stites. Today we are talking about a condition that often flies under the radar but can have a huge impact on a person's quality of life: Sjögren syndrome. It is characterized by extreme dryness. The immune system attacks the body's own moisture-producing glands, leaving people with painfully dry eyes, dry mouth, and dry skin. But it's not just about dryness. It can also affect joints, teeth, energy, and digestion. Joining us this morning is Dr. Gaith Nyase, a rheumatologist and director of the Sjögren's Clinic at the University of Kansas Health System. And also joining me is Dr. Pooja Budbade. I hope I said that correct. She's a rheumatologist here at the health system. And Dr. Budbade introduced us to one of her patients, Jane Morgan, who lives with Sjögren's syndrome. We'll start by hearing a little of Jane's story. Here's Jessica Lovell.
71-year-old Jane Morgan loves spending time outdoors, especially in her garden.
I love flowers. In fact, I kind of replace them halfway through the summer so that they look their best. It just brings me a lot of joy.
But for the past 30 years, Jane has been tending to something else: Sjögren's syndrome. It often starts with pain in the joints.
It was in the early 1990s. I was having a lot of joint pain, and I played tennis, and I couldn't figure out why everything was hurting, and it had been that way for quite a while, so I quit playing tennis, went to the doctor.
Doctors thought it might be lupus, but later it was confirmed to be Sjögren's, an immune disorder that affects the mucus-secreting glands, causing dry eyes and dry mouth. Jane had both and more.
I have had so much dental work done because your mouth is so dry, and at night it dries out, causing a lot of decay. Probably over half of my teeth had root canals. Every one of my teeth was crowned, and then it got to the point that the crowns were starting to break and fall out, to the point that a month and a half ago I had to have all of my teeth removed.
Her team of doctors at the University of Kansas Health System helped Jane manage her symptoms over the years. Through proper medications and monitoring of symptoms, Jane is able to live with Sjögren's.
I just feel so comfortable that I know when I go for my annual appointments with the 6 different doctors that they're going to see what needs to be done, what needs to be tweaked. So I do feel better because of that.
Dr. Nyase, how do you diagnose Sjögren's syndrome?
Well, first of all, thank you for the opportunity to discuss Sjögren's disease today. I believe Sjögren's is a common yet extremely under-recognized condition that deserves far more attention than it has received in the past. Diagnosing Sjögren's can be quite tricky because there's really no single definitive test. We usually put together several pieces: the symptoms like persistent dry eyes, dry mouth, joint pain, but also blood tests like the anti-SSA, anti-SSB antibodies, and frequently a minor salivary gland biopsy from the lip, looking for an immune cell attack to the glands. We might also do an eye test that we refer to as Schirmer's test to measure the tear production, or collect saliva over a certain period of time to estimate saliva output and the gland function. The reason many patients go years undiagnosed is the fact that their symptoms can be pretty unspecific. Dry eyes or joint pain, joint aches might be symptoms that can be blamed onto getting older, being in menopause, allergies, or other issues. Moreover, Sjögren's often mimics or overlaps with other diseases. For instance, in Jane's case, she was first told that she might have lupus. This is a common issue that we often encounter at the Sjögren's clinic, that is misclassification. If the classic dry eyes and dry mouth symptoms aren't obvious, or if the blood test comes back negative, the doctors may not immediately think of Sjögren's. So patients often get bounced between specialists for years treating individual symptoms. It is not unusual for someone to see a dentist for tooth decay, an eye doctor for irritation, and maybe a rheumatologist for joint pain before finally putting the puzzle together as Sjögren's. All this leads to a delay in the correct diagnosis. And finally, I should highlight that the term Sjögren's syndrome can sound like a loose set of symptoms, whereas the term Sjögren's disease reflects a real immune-driven illness with a known biology and whole body impact. With all this in mind, Sjögren's is now recognized as a distinct autoimmune disorder with characteristic systemic manifestations, histopathology, and serological abnormalities. And although the term Sjögren's syndrome has long been used, we believe the term Sjögren's disease is far better, as it reflects the defined pathogenesis and also the clinical seriousness of the disease. The bottom line is that the name change doesn't alter your care, but it can validate patients' experience and raises awareness that Sjögren's is serious and deserves targeted therapy. And this terminology shift was recently formalized through international consensus and published in Nature Review of Rheumatology with strong endorsement from the Sjögren's Foundation, as well as many groups throughout the world.
Okay, great. Thank you for all of that perspective. So when we're looking at this, why do we see this condition most often in middle-aged women? Because isn't that correct?
Yes. Like many autoimmune diseases, it's most common in women, and that's because of hormonal and genetic influences. And it tends to occur between the ages of 30 and 50 because of those factors. And that can be really frustrating for patients because it sort of hits them at the prime time of their lives when they're trying to balance family and work and their personal health. But what's important for patients to understand is that it's not anything that they did to have caused it or that they could have done to prevent it. It's the immune system being misdirected.
Okay, so what's going on with the immune system where then it starts targeting the glands, correct?
Right. So the immune system is sort of our body's defense system, right? It's supposed to protect us from things like infection. So in Sjögren's disease, it sees these moisture-producing glands as a threat. And so immune cells move in, they release inflammatory signals, which recruits more immune cells, and this cycle continues, and that leads to cell damage and cell death, which leads to hypofunction of those glands, meaning you stop producing saliva, you stop producing tears, and that's why patients get dry mouth and dry eyes.
Sure, and I can see why this is tricky because, like, I have dry eye, and a lot of people who take allergy medicine, I mean, you have dry mouth, you start having all of these symptoms and things.
Right.
So I'm sure you're seeing people who have waited years for a proper diagnosis.
Exactly, yeah, like Dr. Noaise said, you know, a lot of the symptoms can be very non-specific and vague, and so sometimes patients don't even realize they have dry eyes or dry mouth. It's sort of a subjective and relative symptom, and so...
And you live with it.
Right, you live with it, you kind of get used to it, and so... and I think people sometimes think like, oh, those are just very mild symptoms, but they can be really debilitating and really affect the quality of life for these patients.
Sure. Dr. Noaise, there is no cure, so what kind of treatments do you do to manage the condition?
Well, management of Sjögren's disease focuses on controlling symptoms and at the same time calming the immune attack. There's really no outright cure yet, but we aim to improve the quality of life and at the same time try to prevent complications. For the dryness, we use a lot of supportive measures for dry eyes. For example, patients use artificial tears or lubricating eye drops frequently. There are even prescription eye drops like the one containing different concentration of cyclosporin that reduce eye inflammation and help you produce more tears. For the dry mouth, we encourage staying hydrated, chewing sugar-free gums and lozenges, or to stimulate, with the goal of stimulating saliva, basically. And we have medications like pilocarpine or cevimeline that can stimulate the salivary glands to produce more saliva, basically. Good oral hygiene and regular dentist visits would be super important here, obviously. Also, dry mouth can be quite rough on the teeth, as highlighted in the case of Jane. Right. So we try to prevent cavities early on with fluoride treatments. Now, beyond moisture replacement, we often use immunomodulatory therapies, such as hydroxychloroquine, a famous drug. It's actually a malaria drug, but it also immune system altering. It has autoimmune or immune system altering properties. It can help with fatigue. It can help with joint pain, rashes. With this drug, it sort of like tamps down the overactive immune system, if you will. It's not a miracle drug, I have to highlight here, but many patients do benefit from it, indeed. If a patient has more severe disease, let's say lung involvement or kidney inflammation, then we might use stronger immunosuppressants, and those could include drugs like methotrexate, azathioprine, sometimes with steroids, corticosteroids like prednisone. And in certain cases, we even use biological therapies, such as, for example, rituximab, especially if the disease is affecting organs in a serious manner or causing a lot of systemic problem. Overall, what's working best these days is a personalized combination approach. We address the dryness with local treatments and lifestyle changes, and at the same time address the immune system activity or overactivity with immune-altering medications if needed. And overall, I would say that by tailoring the treatment to each patient's particular set of symptoms and problems, we can usually get patients to feel reasonably better. It's all about managing Sjögren's as a marathon, really, rather than a sprint. It's through ongoing care, monitoring, and adjusting treatment as we go.
Okay. What other specialties are involved in your clinic? And I'll ask that to both of you. Dr. Nyase, we'll let you go first. What else are you treating in your clinic?
Well, I think without any doubt, Sjögren's demands a team effort. In our clinic, the rheumatologist, that is me, might be coordinating the care, and as we rely on other providers, basically, with other specialties. So an ophthalmologist, for example, is crucial for the management of dry eye symptoms, but also for other aspects of the care, checking for damage of the cornea, for example. Ophthalmologists can prescribe special treatments like the medicated drops, or even procedures like the punctal plugs. And these are the little plugs in the tear duct that help keep the tears in your eyes longer. We also involve the patient's dentist, as they do help patients combat dry mouth, treat fungal infections of the mouth, and generally save as many teeth as possible. We also work closely with an ENT physician, that's an ear, nose, and throat specialist. And what they do is they actually help us quite a bit with a lip biopsy to confirm the diagnosis, but also to manage enlarged salivary glands and chronic sinus issues of dryness. If the patient has, let's say, lung involvement, a pulmonologist or lung specialist would be consulted here. The same case if you have kidney involvement, you bring a nephrologist. Neuropathies or nervous system involvement would sometimes require consulting with a neurologist. So we all collaborate with other specialists in order to optimize patients' care. And then finally, I should highlight that mental care can be an important aspect. This is a chronic illness that can be tough emotionally on the patient. So sometimes psychologists and counselors can be quite helpful and contribute to patients' care. So yes, it's truly multidisciplinary approach as each specialist addresses a different piece of the puzzle, and together we can try to improve care and cover all the bases, basically.
Yeah, so definitely a team approach. Dr. Babade, what are you worried about if you don't address all of these different symptoms? What's the long-term problem? We know dentistry, obviously.
Yeah, I mean, by far one of the most serious complications is B-cell lymphoma if it goes untreated, and that tends to occur in patients who are seropositive, have high inflammatory markers, high immunoglobulins, recurrent parotid gland swelling, but any sort of progressive organ damage can occur in the lungs, for example, with interstitial lung disease, in the nervous system, in the skin, in the kidneys, the liver. So it's a systemic disease, and collaboration with other specialists is really important in not just identifying if the organ's involved, but helping with co-management. And even if it's untreated, the chronic mucosal dryness can lead to recurrent cavities, poor dentition, loss of teeth, oral candidiasis, which is like thrush, corneal damage, and eye infections. And those can be some of the most debilitating symptoms for patients and really affect their quality of life and their functional status.
Absolutely. Is there anything new on the horizon that could help manage Sjögren's?
Yeah, I may defer that to Dr. Nyase. I think he was going to cover that question.
Sure. We'll let you take a swing at that.
Sure, happy to answer this very important question, because there's a lot going on. I would say this is a very exciting time for Sjögren's research, and after many years of having no really targeted treatments, we're on the cusp of real breakthroughs, I would argue. The biggest news has been the drug called ianalumab. This is a monoclonal antibody therapy that targets a subset of the B cells, or the white blood cells that we refer to as the B cells, and the B cells are really big troublemaker in Sjögren's. Just recently, a phase 3 clinical trial, 2 phase 3 clinical trials actually, the largest conducted before the FDA approvals. Usually these are called phase 3 trials. They showed that ianalumab significantly reduced disease activity in Sjögren's patients. So this is huge, because this is the very first time ever by a phase 3 trial was successful in Sjögren's. So we hope that ianalumab might become the first approved treatment specifically for Sjögren's disease as early as next year. There are also recent press release announcing another successful phase 3 trial for a drug called telitacicept. And this is a bit different. It targets molecules called BAFF and APRIL. And in short, what these molecules do, they help these B cells we talked about earlier survive and thrive. This drug was successful in a clinical trial in China, and it showed pretty promising results, improving disease activity in those patients. It's not yet approved, as in the case with the other drug, but it's generating a lot of optimism. We also have new approaches to tackle the autoantibodies, like the anti-SSA and anti-SSB antibodies that are famous and important for the diagnosis. Those are the antibodies that attack the patient's own glands and other tissues. We have two experimental drugs here. One is called nipocalimab, and the other one is called efgartigimod. And these two agents work by sweeping out those antibodies from the circulation, those pathogenic, ill-defining, ill-causing antibodies are swept out of the circulation. They specifically block a receptor that we call the FcRn. And what this receptor does is actually protect those pathogenic antibodies from breakdown. And by blocking this receptor, these drugs can help the blood clear out all these antibodies faster. And in early trials, both have shown to improve the symptoms of Sjögren's, amongst other parameters. In fact, these drugs both of them were promising. That in the case of nipocalimab, the FDA granted the fast track status for Sjögren's, and that is to speed up the development. Another interesting avenue is oral medications that kind of sort of tweak the immune system in a more targeted way than older immunosuppressants that we use over the last 40 years. For example, there's a drug called deucravacitinib, which is available now in the market to treat psoriasis. And what it does, it's being tested now for Sjögren's in a phase 3 clinical trial, and the data from prior studies seems to be rather promising. And then finally, I should highlight this, which I believe is a very important point. There's a big buzzword in research in the field of autoimmune diseases, including Sjögren's, and that is the term personalized medicine. And Sjögren's disease for years has been recognized as notoriously heterogeneous. And what I mean by heterogeneous is that patient A can be very different or deal with different issues compared to patient B. For example, one might have mostly dryness and fatigue. Another patient might have severe lung inflammation or kidney disease. Underneath that diversity of clinical symptoms and presentations, there are also different biological pathways that govern those symptoms in different people. For instance, some patients might have what we call high interferon levels in their blood. Others have high B cell activity. So current research is trying to stratify patients into subgroups based on blood and other tests called biomarkers. And by doing so, those clinical trials can be more targeted. And for example, a drug, let's say a drug that blocks the B cell pathways might work amazingly for a subgroup of Sjögren's patients in which the B cells are hyperactive. While other drugs can be targeting other patients with different mechanism of inflammation. In the past, some Sjögren's patients' trials might have failed, possibly because they threw everyone together. And now we're learning to reduce that kind of heterogeneity in studies, essentially matching the right patient to the right drug, if you will. And this approach could improve patient success rates quite a bit. As I highlighted, like certain medications can target certain pathways of inflammation. So there's a lot of hope in the horizon. And after decades of using mostly generic medications, we finally see therapies developed specifically for Sjögren's. And if those trials keep succeeding and medications get approved, then the way we manage Sjögren's could dramatically change in the next few years, from just managing symptoms to actually modifying the disease process itself. It's really hopeful time for patients with Sjögren's, but also for the doctors alike. And we're eager following all these developments.
Okay, great. Thank you for that. And of course, we are here to answer your questions. Send them in using the links on your screen. We have YouTube, Facebook, or you can email the Medical News Network. Now let's check in with Doc Hawk. A recent poll revealed that only 36% of women consider the mRNA vaccine to be safe during pregnancy. And Dr. Hawkinson, we know there is scientific evidence to support the vaccine. So why do you think that there is hesitancy for these expectant mothers?
Oh, for sure. You know, we do know and understand that expectant moms are going to be very cautious about anything that impacts them and especially their baby, and that is a normal feeling. But what we have seen with this study is that while 36% of women consider the COVID vaccine safe, which is still a very small percentage, unfortunately, 28% of expectant mothers believe it's incorrect to say vaccination is safe for pregnant women. And unfortunately, there's been a lot of misinformation circling online and kind of in everyday life that can make it hard for those women to know who to trust, and really for the general public. You know, as we saw early on in the pandemic, pregnant women were not involved in the initial vaccine trials. However, subsequent studies after the marketing, after the use of the vaccine, again, this is the most used vaccine in the world ever. That data, that science has shown that the vaccines are extremely safe and effective during pregnancy. What they do is they provide protective antibodies that the moms make when they get vaccinated. Those antibodies then are transferred through the bloodstream and the placenta to baby to give that baby protection from COVID for those first few months of life. And what we should say, and the underlying message, is that COVID vaccination is safe during pregnancy. It's effective and also provides, as I stated before, protection for mom and baby as well.
Okay, of course, many expectant mothers, they worry about those potential side effects. I've been there, I know that. Yeah. But can you share what research shows about fetal outcomes after COVID vaccination? I know you kind of touched on that.
Yeah, and so we'd like to just start with the group in America that is really tasked and dedicates their whole lives and careers towards creating making mom and baby safe, and that is ACOG, or the American College of Obstetricians and Gynecologists. And they recently released their newest recommendations and a statement in August of this past couple months ago about COVID vaccination and pregnancy itself. What they said was that the data show that the COVID-19 vaccines are particularly effective at reducing morbidity from COVID-19 complications in pregnant patients and their infants, so both mom and baby. And this is measured by emergency department visits and clinic visits as well, also hospitalizations. And the data support the benefit of vaccination in reducing pregnancy complications such as severe maternal morbidity, preterm birth, and stillbirth. And again, we know, as we have just talked about, the concern for baby. Well, what the data show and support, and this is coming from ACOG, due to the post-marketing studies, is that the vaccines do help actually reduce those risks in mom and baby as well. And so more importantly, during pregnancy, this provides passive immunity. As I said, the antibody transfers from mom into baby. And also that maternal COVID-19 vaccination during pregnancy also results in significantly greater antibody persistence in baby compared to those mothers that were not vaccinated but actually got COVID-19 itself. So you're getting a better immune protection from getting the vaccine than getting the disease itself. And finally, just to put a cap on this conversation, their final statement is that the data strongly show that COVID-19 vaccination is not associated with a negative effect on pregnancy outcomes. So I think that being said, from the group that we task with keeping our moms and babies healthy during pregnancy, again, continues to support the fact that COVID-19 vaccination is safe. And we do know and understand that besides the the age group that is over 75 years and older, we know that those very young babies are the second highest group to have potential adverse outcomes from getting COVID-19. So if you can protect baby, that is very good and that is wanted. We know that, again, maternal vaccination can help provide protection for baby as well. And one other thing, as we've talked about with Dr. Stites all the time, is that, you know, we practice evidence-based medicine, and we have to continue to say that the evidence continues to support the safety and efficacy of COVID-19 vaccination. And again, as we had just stated, especially for mom and baby. And I just heard a podcast the other night called Star Talk, but one of the good things, one of the quotes they said was that data is the ultimate arbiter. And as we just said, we have just a plethora of data, a large amount of data to support the safety and efficacy of these vaccines. And so what this, I think, this study is not just about mom and baby and COVID vaccination, but unfortunately, just as you said, it is about misinformation. And now we have to tackle misinformation and fight misinformation every day in the medical profession for the common goal that we all want, and that is the well-being of our patients. And I would also just like to say that, we just saw that yesterday in the Washington Post, 6 former Surgeon Generals did write an op-ed piece talking about the current state and the climate going on right now with misinformation and how that can lead to further potential problems, increase in infectious diseases, especially those vaccine-preventable diseases and other chronic illnesses, just with all the misinformation that is currently going on. So we have to continue to fight that every day, try to provide the best education to our patients and the public, and just try to keep everybody safe.
Okay, follow the science. Thank you, Dr. Hawkinson, and we'll see you next week.
Thank you.
Now let's get to some community questions this morning. Let's bring in Jessica Lovell. Good morning, Jessica.
Hey, Angie, good morning. Jeremy wants to know, does Sjögren's make you more likely to get lymphoma?
Do you want to tackle that?
Yeah, I think I mentioned that earlier. That is one of the most serious complications. Again, it tends to occur more in the patients who have seropositive Sjögren's, so that SSA antibody, SSB, a positive rheumatoid factor. They have high inflammatory markers, high immunoglobulins, and they tend to get like recurrent parotid gland swelling. So, hopefully if clinicians are asking patients about questions about like fevers, night sweats, unintentional weight loss, unusual fatigue, which can be a tricky symptom because a lot of patients with Sjögren's struggle with fatigue. But there are certain markers and labs that us as rheumatologists can monitor regularly to see if you might be headed towards that direction, and obviously asking any symptoms as well.
Okay.
Luke wants to know if this is genetic.
Dr. Noase, do you want to tackle that one? Is it genetic?
Sure. Yeah, I mean, the answer is it's not that simple. There's no straightforward answer. Unlike monogenic disorders like sickle cell disease, in which you can literally predict the risk of the offspring of the patient based on simple calculations, Sjögren's is like all other autoimmune disorders considered polygenic. And polygenic means that there are so many genes involved that we have not even discovered yet. So for now, as of now, in the case of Sjögren's, we have discovered about 20 or 25 genes, and the numbers are getting better. But in the case of rheumatoid arthritis, you have hundreds of genes. So we haven't discovered them all. We're in the process of doing so. But importantly, the mode of inheritance is unpredictable. You don't know how many of those genes are going to be transmitted to the offspring of the patient, and therefore it's impossible to predict how likely they're to contribute to the disease onset in a given subject. That said, genes in Sjögren's, unlike with genetic disorders, are not sufficient in causing inflammation. You need something from outside, and that's really the model of autoimmunity as we understand it now, is that we believe that there's an interaction, a complex and not fully understood interaction between environmental factors like viruses, like maybe the food that we consume, maybe it's some certain chemicals in the air that we breathe, along with the genes that interact together and lead to inflammation. So the genes are involved, but they're not enough in causing Sjögren's.
Got it. Okay, thank you for that. Dr. Babade, what about a final thought? What do you want people at home to know about this syndrome and how we're managing it?
Yeah, I would say that I think a lot of patients with Sjögren's disease end up being diagnosed as just fibromyalgia. And so when for clinicians, when you see a patient with symptoms coupled of like fibromyalgia with chronic widespread pain and fatigue with an elevated ANA blood test, you should consider more objective signs of dryness, looking for more objective signs of dryness, because they may in fact have Sjögren's disease, and that could lead to a confirmation of a diagnosis that could, change that patient's, their life. So I would look for more objective signs of dryness from a clinician standpoint. And for patients, because the dry symptoms, the fatigue can be really debilitating and frustrating to deal with, looking at non-pharmacologic management techniques is important. So diet, exercise, mental health, and sleep habits is really important. And for clinicians, I think like looking at modifiable factors like looking for sleep apnea, restless leg syndrome, vitamin deficiencies, thyroid disease. There's other factors that could be contributing to some of their symptoms as well.
Sure. Okay, thank you very much. We really appreciate your perspective. Final thought from you, Dr. Noasai?
No, thank you so much for the opportunity. I would say this is a very exciting time in the field of clinical care and research in Sjögren's. And again, the Sjögren's community is anxiously anticipating FDA approvals as early as 2026. And I suspect that within 3 to 5 years, the treatment landscape is going to fundamentally change to the benefit of the millions of Sjögren's patients all over the world.
Okay, thank you again for joining us, both of you. And thanks to our audience for watching. Have a good day.
I'm Alexis Del Cid. On the next All Things Heart, this former Kansas City Chiefs player is used to battles on the field. His new opponent lives inside of his body. His new teammate off the field works right here at the University of Kansas Health System. That's Thursday at 8 a.m.
Subscribe to our morning medical update and Open Mics with Dr. Stites podcasts. Now, everywhere podcasts are available.